Uh, Good morning, everyone. So I want to welcome all of you for our webinar today entitled Participant Recruitment and Retention, Common Challenges, and Recommended Strategies for HIV Prevention, Research, and Practice. So this is put on by the Evaluation Center funded by the Chicago Department of Public Health, which is a collaboration between the Impact Program at Northwestern, CPIM at Northwestern, and the AIDS Foundation of Chicago. So just before we get started, there's a few instructions I want to announce to everyone. So all of you are currently in listen-only mode, so you won't be able to speak. We won't be able to hear you if you say anything. You can submit questions at any time using the chat feature, and so feel free to do that anytime during the discussion, and we'll be able to talk about any of the questions at the end. We also have a lot of attendees on this call, so we won't be able to unmute the phones at the end so you can ask questions. So please just type in your questions and we'll get to them as we work through all of the responses. So the two ways you can do that are either to raise your hand or use the question feature to ask questions. So you can raise your hand if you have a question, although we recommend that you just type your questions into the question box. We will be looking at the raise your hand if you have some issues with audio or anything, but otherwise please just send in your questions by typing it into the box. If you have any questions that we don't get a chance to cover today, or if you don't feel comfortable asking anything today on the webinar, you can either contact Mallory, Edgar, or me, Gregory, Phillips, with any additional questions. Our email addresses are there. So just a little bit about who we are. So I'm Gregory Phillips. I'm the principal investigator for the Evaluation Center that's holding this. I'm also a research assistant professor at the Impact Program at Northwestern. The majority of the speaking, though, will be done by the rest of the people listed on the list here. So we have Mallory, Edgar, who's the Evaluation Center project coordinator, Crystal Madkins, who's the Keep It Up project director with the Impact Project, Christopher Raley, who's the medication adherence consultant at Howard Brown, and Dwayne Quintana, who's the HIV testing and linkage to care manager at Chicago House, who also is a chaplain and has experience working on Keep It Up with Crystal. So we want to show some of our learning objectives for this webinar. So we have two main things that we want participants to be able to do at the end of this webinar. We want everyone to be able to discuss factors that could impact recruitment and retention in HIV prevention interventions, programs, or research studies. We are talking mostly about HIV prevention studies, but a lot of the topics we talk about are relevant outside of the HIV field. And we also want you to be able to describe multiple strategies, tools, and tips to improve recruitment and or retention efforts in your daily work, either in research or practice. So before we get started on talking about what these strategies are for improving retention and recruitment, we want to give you some quick definitions just so we're all on the same page about what we're talking about. So by recruitment, we mean activities that are intended to bring people into a research study or an intervention. This is a selection process that targets appropriate people who are representatives of the target population, whatever that might be for your particular project. And by retention, we mean the process of keeping participants in a research study or intervention. And these are activities intended to develop and maintain relationships with participants and a way to encourage people to continue to participate in the study and keep coming in for any sort of follow-up visits or other contacts.
Great. Thanks, Gregory, for getting us started with all of this. This is Mallory speaking now from the Impact Program at Northwestern. Pardon me. So the rest of this webinar is divided into two broad sections. So in the first one, we're going to briefly review some of the major factors that can influence recruitment and retention efforts in HIV prevention interventions or research studies. Just a disclaimer up front, this isn't intended to be an exhaustive list. I'm sure that everyone listening could think of even more things to add to this list that could potentially impact or have impacted your own recruitment or retention activities. But we wanted to make sure that we acknowledge some of the bigger challenges that we know from our own experience with recruitment and retention, from our colleagues' experience, and from the research literature before we move into the meat of the presentation where we're talking about strategies and tools. So we're going to touch on both agency level and participant level barriers. sociocultural issues, ethical concerns, and lastly, sampling and design. So starting first with agency-level barriers, I'm sure that everyone on the line today has run into at least one of the bullet points that you're going to see listed on this slide here when you've been trying to actively recruit and retain participants in a program. So limited resources is something that can impact every stage or process in an intervention or a study, including recruitment and retention. So you may not have enough staff members to shoulder the burden of recruitment and retention, or the staff that you do have may have limited time to devote to these activities. Anybody who has had this as a job knows that recruitment and retention could be a full-time job for anyone. So if you have other responsibilities for a given project, or you're maybe managing other activities, it can be really hard to devote all of the time that you need to recruitment and retention. Your agency might also have not have the financial or logistical capacity to provide things like overtime pay or flexible scheduling for staff to be able to engage in more diverse recruitment and retention activities. And then you might also be limited in terms of the amount of materials that you can purchase, both promotional and educational materials, as well as things like condoms that could be an incentive for people to become engaged and stay engaged in a project. So some additional staffing challenges can include things like the team dynamic. So is everybody cooperating and working together as a team? Are they supporting each other and putting their heads together to troubleshoot any problems with recruitment and retention? There's also the issue of training. So is the agency providing appropriate training to staff on how to recruit and retain participants? And are there ongoing discussions about cultural competency, particularly if you have recruitment and retention staff that are working with target populations that they're maybe not a part of or haven't interacted with before? And then relatedly, are your recruitment and retention staff comfortable working with the communities being targeted? So especially if you're doing any like things related to agency funding and ability to purchase different resources or staff time and things like that aren't things that we're going to address explicitly in any of the strategies and tools that we discuss later in the webinar, since these are kind of bigger issues that are a little bit outside of the scope of this 90-minute webinar for us to address. But we did want to make sure that we at least acknowledge these things up front, knowing that some of these things that are operating in the background and sort of behind the scenes with interventions or studies can definitely impact something like recruitment or retention. So there are also a number of challenges at the participant level that can come up, and these are probably some of the most familiar challenges for a lot of the people listening right now. So many of these are purely logistical. There is, of course, a time commitment that's inherent in participating in a study or an intervention. And if a participant is busy or they maybe feel like there's not enough incentive for them to participate, they may not be willing to give up their limited free time for your project. And this is particularly true for multi-session interventions or longitudinal studies where the time commitment isn't just, a single session or an afternoon or a weekend retreat. Socioeconomic barriers may also exist, so they may not have the money for transportation to get to where they need to go for the project. And then they may also have work schedules to contend with and a job that's maybe not flexible enough for them to leave early or swap hours with a coworker to be able to make it to sessions as needed. For research studies in particular, protocols and procedures can often be complex and confusing. So this may deter individuals from participating, especially if they've maybe never participated in a research study before. And then lastly, there's also the potential issue of changes in eligibility over the course of a program. So a good example is if you are doing a study or an intervention that is targeting a specific age range, a participant may age out of the program. So that's something that you have to think about ahead of time and make some decisions about how you're going to deal with that as an obstacle and whether or not if someone ages out, if that means that they have to drop out of the intervention or the study, or if they can stay in as long as when they entered, they were within that age range. So beyond the logistical challenges, there are also some potential educational and emotional barriers. So participants may lack awareness of a particular issue, which could make them disinterested in participating. And then there's also the issue of either perceived or an actual lack of knowledge on the part of providers or staff that are doing the project, which could deter individuals from signing up or staying engaged if they maybe feel like the people they're interacting with in the project don't really know what they're talking about or don't understand them or their community. Also, a lack of appreciation. So participants may not value the intervention or study. So, for example, seronegative individuals may not prioritize preventative interventions once they've already tested negative. And then also participants may not feel like they or their time are fully appreciated by the study or the intervention staff, depending on how interactions with those individuals go. And then lastly, communication can be a challenge, both in terms of literacy level and language. So that's something that you have to keep in mind when you're developing things like recruitment scripts or outreach materials like flyers and things like that. And then finally, one thing that we talk about a lot in the public health field, I know, is the challenge of competing interests and priorities for participants. So while we know that HIV prevention and sexual health promotion are so important, and potential participants themselves may also really value the work that's being done and what they can get out of participation, they may simply have other needs that are more immediate or outweigh their need to participate in your intervention or study. So something like securing housing or getting food assistance or mental health services, those things may take priority for some of the participants. So it's not necessarily about them not thinking your intervention or study is important. They just have other things that are a little more pressing. So barriers to engagement may also be social or cultural in nature. And in our particular field, the issue of stigma is a pretty big deal, as I'm sure a lot of folks on the line are well aware. So there's both HIV-related stigma and LGBT stigma and homophobia to contend with. So people may not be eager to participate in a project that is focused on HIV because of some of the negative connotations that are associated with HIV/AIDS, or because they don't think they're at risk, maybe based on some prevalent myths about HIV/AIDS and who it affects. And one of those myths is that HIV/AIDS is a disease of, gay men specifically, or the LGBT community in general. So there may be a fear of participating in an HIV-specific project if a participant doesn't identify as gay or doesn't want to be perceived as gay, or just has concerns about confidentiality around these issues. So we have to think about the influence of stigma, and we also have to think about cultural fit for specific subgroups. So these are things that will impact whether or not you get a yes from an individual to participate in the first place, and will certainly impact whether or not they keep coming back to your project. So in the HIV field, we work with really diverse communities. I'm just going to touch on a handful of those here to give you a sense of the kinds of questions you should be thinking about when you're thinking about recruitment and retention. So for trans and gender nonconforming individuals, do they feel comfortable and safe in the space? Is the language that's being used appropriate and affirming? Do your staff ask about and use correct pronouns? And when they're in the space, are there bathrooms available that they can use that accurately reflect their gender identity or expression? Thinking about youth, does the program cater to the unique needs of young people? So do you address and affirm confidentiality and non-disclosure to family, both in terms of HIV or STI status, as well as sexual or gender identity? And then can you be flexible with scheduling conflicts related to school or extracurricular activities? And can you maybe provide assistance with transportation for people that maybe don't have access to a car if they have to travel a long distance, or maybe don't have a license and aren't even able to drive if they did have access to a car? Thinking about individuals who use or abuse substances, do they feel safe sharing information about their drug use habits, or are they worried that they might potentially be punished for admitting to engaging in illegal activities? And then lastly, racial minority groups. Is your project culturally sensitive and affirming? So do you address and assuage any concerns that they may have about how trustworthy your organization or project is? So we know that the issue of mistrust is a really real concern, especially for communities of color, as a result of a pretty long history of maltreatment on the part of medical and public health institutions in the U.S. And this history has contributed to some narratives about, HIV being a man-made virus or being something that was developed as a weapon against these communities. And I think that it's something that those of us in the field, it may be easy for us to dismiss that as, an outlandish conspiracy theory, but it's rooted in some really real experiences and feelings, and I think it's something that needs to be kept in mind, and you need to be mindful of as you're doing recruitment and retention with these communities. And the point about mistrust and maltreatment from the last slide is actually a really good segue into a discussion about ethical concerns. So I think we often think about ethics as being most closely tied to research, and it's certainly important in that context, but it's just as important in any non-research intervention or program. So first and foremost, when you're inviting individuals to participate in an intervention or study, you have to be sure that their participation is truly voluntary, that they're not participating because of undue influence or coercion. So the use of incentives is actually a really great example of this ethical concern. We know that offering incentives, monetary or otherwise, is often really important for getting participants engaged in the first place and keeping them invested in the program, making them feel like they're appreciated for their time and their contributions to the study or the program. But something that your team always needs to ask themselves is whether or not the incentive is perhaps so large or important that its influence over the participant is strong enough that it's almost coercive, that they don't really have an option to say no to something that they really need. Also, some method of informed consent should be present in any of the work that you're doing, not just research focused. So before a participant ever agrees to be a part of your study or your intervention, they need to know exactly what their participation entails. So they need to know what's expected of them, what they can expect in return, what to do if they feel uncomfortable or unsafe or want to quit. And you also need to make sure that they have just all the facts in general before they say yes, so that yes is truly an informed one. And then your team also needs to consider the potential of any conflicts of interest with your recruitment or retention activities. Often staff working on these activities may be of the community that you're targeting, and this is really great when you're thinking about cultural fit and having your staff and your program reflect the community that you're working with. But it also has the potential to create potentially uncomfortable situations for staff where a recruiter is maybe interacting with or enrolling friends or other people from their social network. And then finally, you may utilize recruitment techniques that actually ask current participants to identify people within their social or sexual networks and recruit those participants into your project. And often when you use this method, you give incentives to those original participants. So maybe they get a $10 gift card or something like that for each person that they successfully refer to the project. Again, this is a space where you have to consider whether or not this incentive might unduly influence recruiters to enroll people that maybe aren't exactly right for the intervention or the study. Maybe they don't really fit the inclusion criteria, but they're referring them in order to get that incentive. And then the last thing we wanted to touch on in this influencing factors section is sampling and design challenges. So two types of studies or interventions can be particularly difficult, and those are partner-based interventions and longitudinal or multi-session programs. So thinking about partner-based interventions or studies, we know how difficult it can be to recruit a single person. It, of course, gets even more complicated when you're trying to get a couple enrolled. So both partners need to be eligible for the program. So if a program is focused on men who have sex with men or MSM couples, that would exclude any female partners. So maybe one partner that you engage with does fit the criteria, but they're currently in a relationship with a female, and so they wouldn't fit the as a team, as a couple, they wouldn't fit the criteria. Also, both partners need to express interest and agree to participate. And if one partner decides that they're maybe not interested or they lose interest after they've already been recruited, it can be really difficult to keep both of them in. And then you also have to think about passive versus active partner recruitment. So often what happens is that your recruitment staff is interacting with a single person, and then you sort of rely on that person to recruit their partner. So that would be more of the passive partner recruitment, whereas active would mean that you are engaging directly and equally with both of the partners. And sometimes that can be a lot more useful to make sure you're keeping both of them excited and engaged in the project. And then for longitudinal or multi-session programs, of course, by their nature, they're over an extended period of time, which means that there can often be large gaps in between appointments or visits. And it can be really easy for, pardon me, even the most well-intentioned participants to forget about the project or lose touch, or maybe their phone numbers or their addresses change and you can no longer get a hold of them. So staying in contact becomes really important, and we'll talk a little bit more about that later in the webinar. And then finally, the type of recruitment strategies you use may impact your intervention or study population in significant ways. So a number of studies have found associations between different risk behavior groups and specific recruitment strategies. So for example, one study found that in the populations that they were working with, men with 10 or more partners were more likely to be recruited through advertising and street outreach, and men reporting unprotected sex were more likely to be recruited by clinic referral. So having this information about the best methods for individuals in certain risk categories can be really beneficial for something like a clinical intervention where you're trying to target a very specific risk group. So it could be problematic for research samples when you're thinking about how representative your sample is of the larger population you're wanting to reach and how generalizable your results are to that broader population. And then you may also have to think creatively about how to reach hidden populations. So, for example, a lot of research with men who have sex with men focuses largely on highly visible men, so those that maybe are going to gay bars or bathhouses or pride events. But that leaves out some less visible or more stigmatized groups such as MSM of color or youth. So it's something that you have to think about in terms of how do you really get at all of the people in the population you're interested in so you're not missing potentially these huge swaths of the community. So that was an overview, again, of some of the big challenges that you can encounter in trying to plan for and actually do recruitment and retention activities. Again, that isn't an exhaustive list, but we wanted to hit on some of the really major influencing factors. So in the remaining slides, we're going to go over some strategies, tips, and tools that can be helpful in addressing some of those challenges that we just reviewed. So we've grouped these strategies into 5 categories. The first 3, community outreach, referrals, and online strategies, are particularly relevant for recruitment activities. And then the discussions around logistical fixes and communication are also helpful for recruitment, but are especially meaningful for retention and keeping participants engaged. And we've also included a couple of case studies in this section, one from a research perspective and one from a practice perspective, to highlight some of these strategies that we'll be discussing in practice here in Chicago. So when you're thinking about doing community outreach, jumping into this section first, the first thing that you really should take the time to do is a little bit of homework about your community. So there are a number of ways for you to gather information about common characteristics of your target population and the best ways to reach them. So you can review epidemiologic profiles that you've compiled or have been compiled by someone else. You can conduct key informant interviews or focus groups or brief surveys to help you find out things like what's important to the community, who are the gatekeepers or opinion leaders, where does the target population congregate, and that's especially important if you're wanting to do some of that, again, venue-based or street-based outreach for recruitment. So when you find out this information about places where the population maybe congregates, it can be good for you to physically scout out any sites before you actually go for the purpose of recruitment. So it's good for you to go on different days and at different times to see what that space or that venue looks like at those different times, because we know that things can change pretty dramatically depending on the day and the time of day. And then you should also be sure to find out whether or not staff from your project will be welcome in the space or neighborhood, because you, first and foremost want to be respectful of any space that you're entering to do recruitment. And then another great thing to do, that last bullet point on the slide, is to coordinate with community-based organizations who are known and respected in the community to learn more about the target population, and also to help you build some more credibility and respect with that community. So when you're thinking about that scouting out piece, sort of doing your homework about recruitment sites, one specific method that you can use is the creation of cognitive maps. And this can be a really helpful reference for your recruitment staff. So you can do these things called reconnaissance walks, which are essentially just scouting out a space. And when you're doing that, you can sketch just a quick map of what you're seeing in that neighborhood or in that space, like the picture that you can see here pulled from the article by Stadler. And then once you do that, you can do semi-structured interviews with community informants that you identify and have them explain to you the significance of those physical locations. So the map isn't just telling you what the name of different things are or where they're located, but also like what they mean to the community members. So it can help you determine places where community members congregate, or places maybe that you should avoid, either because of safety or out of respect for that space. So those are some tips for the doing your homework piece of community outreach. And now I'm actually going to hand it over to Crystal for the next couple of slides to talk briefly about venues and publicity.
Thanks, Mallory. So another great strategy to use when you're doing community outreach is to consider a variety of venues, because this can help address some of the generalizability issues that Mallory mentioned in the previous slides. So there are various techniques for outreach. So one is doing active street reach, which is typically a little bit of a less structured approach, and you're reaching out to folks as you encounter them. So recruitment specialists typically will move through a neighborhood or event, and then, like I said, just engage and screen the people as they come in contact with them. Some of the places to do this type of street outreach can be community events, even if they aren't explicitly health-related. So in the past, for example, impact program teams have done recruitment outside of concerts. We've also gone to general pride events. So of course, there's sexual health information being given, but it's also just a celebration event that you can go to. Typically, when you're doing active street outreach, it's a great idea to recruit in pairs. So typically, one person can be the icebreaker. So this is the person who will make the initial contact with a person, just maybe saying hello or asking them how they think the event is going. And then once they begin that conversation and get them interested in participating possibly, they would then be handed off to the second recruiter, who can provide more information about the study and then also obtain contact information. Another way of doing outreach is to do fixed site outreach. So this is this tends to be more regular and structured than your street outreach. So for example, in the past, we've had research teams that have partnered with popular bars and bathhouses in the community to offer testing and resources on a set day and time every week. And it's important to note that for the fixed site outreach, you can also use some of the tips that you would use for active street outreach. So for example, the idea of partnering with another recruiter, so one person being the icebreaker and another serving as the person who's offering more study information. So when you're doing community outreach, it's also good to get your study or your program's name out through publicity. So some ways of doing that is giving health communications and presentations at community forums, health fairs, and agency meetings. So in the past, impact teams have done sexual health presentations at health fairs and college group meetings, and it's served as a great way for participants to learn about our program in general, and then also learn more about specific projects that they can potentially participate in. You can also use print and electronic media. So we've done flyering in the community, and we've also done advertisements on a variety of online media, which you'll hear a little bit about later. You can also do advertising on telephone hotlines. So these are typically party lines where you can leave a message and then have potential participants respond to your voicemail. And then there are also social marketing campaigns and community mobilization campaigns that you can replicate, for example, from agencies like CDPH and the CDC. So the image that's actually on this slide is the Testing Makes Us Stronger campaign that was developed by the CDC. But if you go to their website and you look at some of their campaigns like this, they actually encourage community organizations to replicate and also potentially use their materials for their own outreach purposes.
Great. So this is Mallory again, and just one last thing in the community outreach section of the webinar. When you're doing any community outreach, you need to also make sure that you take into account safety and support for your staff that are doing recruitment activities. So even though it may not always be possible because of some staffing challenges like we alluded to in the influencing factors section of the webinar, you should aim to always recruit in teams, not just as individuals. So this is helpful not just for safety purposes, but also for engaging potential participants, as Crystal noted a couple of slides back, about using that sort of icebreaker and then handoff routine. So then also anytime that you're sending staff out into the field for recruitment, you should always create backup and emergency plans. And I know this might sound like a duh item in this section, but it's really important to make sure that staff know what to do in case of injury or threatening situation that they may encounter. And then home base or your agency or supervisors should know the team's location at all times. So there should never be a case where your recruitment team or an individual doing recruitment by themselves is, going out to a venue or a neighborhood or an event and no one knows that they're going there, because if something should happen, nobody will know how to reach them. So then beyond doing that active recruitment via community outreach, a more passive way to get some folks enrolled in your study or your intervention is the use of referral networks. So developing referral networks is another way to help with issues related to sampling and getting at your target populations by making use of other people in your professional network that are interacting with the same or similar target populations. So you want to identify providers of services and then develop with them some reciprocal agreements with them about referrals so that you know that they're sort of you're mutually thinking of each other when it comes to referring people to services that you both know are at each of your sites. And you want to, when you're thinking about people to connect with, to think beyond just the more standard HIV-specific services that are offered, to think more about broad prevention services. So things like substance abuse treatment facilities, homeless shelters, DV programs, health department-related services, because even though these may not be HIV-specific, they're going to be seeing a lot of the same people that you are currently seeing or are wanting to see in your HIV-specific studies or interventions. And then when you're thinking about creating these referral relationships, you want to be as transparent as possible and provide as much information as you can to the other providers and agencies that you're connecting with. So make sure that you share information about your project and the results of the project, even if they're preliminary. So another great thing to make sure that you provide to anyone that you're trying to establish this referral relationship with are some how-to materials. So it doesn't have to be anything really extensive. Maybe it's just like a 1- or 2-page document that outlines who your agency is, what your project or study is, and is trying to accomplish, and then really clearly outlines who your target populations are, because that can help the folks that are working at that other organization to have a really clear sense of what you're doing and who you're looking to engage. So that can be really important, either just giving a document like that or having that document and maybe going to that site to do a little training to make sure that staff know exactly who they're looking for to refer to your project. So another really useful method for recruitment is using online strategies. So I'm going to hand things back over to Crystal now, and she'll talk about this over the next several slides, starting with a case study from an HIV prevention research project that she manages at Impact Program.
Thanks. So yes, I am the project director for a study called Keep It Up 2.0. So Keep It Up 2.0 is an online HIV prevention randomized control trial for young men who have sex with men, and we're particularly focusing on men between the ages of 18 and 29. The project is multi-site, so it's in Atlanta, Chicago, and New York, although we've also done some national outreach. And what we're doing is we're comparing our multimedia, interactive, and holistic intervention to a more didactic and general HIV informational control arm. So we originally planned to have participants only recruited through our community-based organizations, but because of reasons I'll get into a little bit later, we decided to expand to using a greater variety of sources. So some of these included online and print ads, participant registries, and outreach events. So the overall goals of Keep It Up are to test the efficacy of our intervention, and the main outcomes we're looking at for this are condomless anal sex and STI incidents, particularly urethral and rectal chlamydia and gonorrhea. And then we also want to see if the intervention has differential efficacy across subgroups. So for example, are there racial differences? So due to slow recruitment at community-based organizations, some of this having to do with structural issues at organizations or high turnover of staff or issues with technology that we wanted to use, the study team, like I said, decided to use a variety of recruitment sources, with online recruitment becoming the standout recruitment strategy that we use. Some of the recruitment that we did online were on dating apps like Grindr, Scruff, Adam for Adam, also on some social networking sites like Facebook, Craigslist, and e-newsletters. So these e-newsletters were email blasts that went out to people who were on listservs for things like sex parties or particular sexual partner interest groups, so people who are looking for twinks or bears in particular, for example. And then all of these ads would eventually link out to an online pre-screener where we would get a preliminary eligibility from all of the folks who did the screener. So the great thing with our online recruitment was that where we initially had only maybe 30 participants who were enrolled in that first year just using community-based organizations, we've now been able to enroll over 800 participants at this point. And actually 60% of all of our enrolled participants have come from one of these online sources. So when you're doing online recruitment, it's also important to still have that personal touch. So when we have someone who screens as eligible through one of our online ads, we have a staff member call participants within 48 hours for the best response rate. So this is typically because people are more likely to remember that they did the screener and also still be engaged. So when we do those calls, we provide more study information to the potential participants. If they're still interested, we then offer to schedule them for an HIV test at one of our CBO partner sites or university site. Or like I mentioned, if they're a person that's living beyond the 3 cities, we will also offer to do at-home HIV testing nationwide. So some of the benefits of doing the online recruitment has been that it's been less work for our community partner sites, and we've also had more control at the university sites. So the study team has had more of a control over this type of recruitment. And we've also been able to reach a greater variety of YMSM, so this is once again getting towards that issue with generalizability. So the first specific ad tip that I have is from Facebook. So we've done quite a bit of Facebook recruitment across all 3 sites. So typically when you go to set up an ad for Facebook, you're first asked to consider your objective. So for example, are you trying to get more clicks on your Facebook study page or get people to install an app that you're advertising? Typically with our studies, we set as our objective to drive people to our online pre-screener. So we're trying to drive traffic to a particular website. So then once you select your objective, you get to the fun part, which is entering information that helps you target your ad to a particular population. So for example, this ad that you see right now, we were able to target it towards Latino and African American YMSM. So you're able to do targeting by, for example, entering zip codes if there are particular sections of cities that are linked to particular demographic groups you're interested in. You can also use interested in or interest to target your ads. So when you're doing interested in, we're talking about men interested in men or men interested in men and women. When we're talking about interest, we can be thinking of things that are like pop culture phenomenon, or we can also be thinking about social awareness campaigns. So, for example, no hate. You can use both at the same time, but if you do so, you should be aware that you're potentially reducing your reach. Something else that we've done is we've used targeted ethnic affinity. So with this, you can select to have your ad displayed to African Americans or Latinos who are either bilingual or Spanish speaking. There are also options to target other groups like Asian Americans. You can also connect your ad to your Facebook page. So with our ad, for example, you can see that it's linked to the Impact LGBT Facebook page. And this is a great way to kind of emphasize the trustworthiness of your study or your program because it's linking back to a page with an official logo. They'll also be able to see a little bit more about how your program has benefits for them, but also the community in general. And then finally, what we've seen is that images of couples in ads have been most successful. So like in this example, either couples that are close to kissing, hugging, canoodling, etc. And there's one additional image that has also proven popular for our Facebook ads. So the next example is for Grindr, but it can also be applied to other mobile applications. So typically when you're doing advertising on these type of apps, we recommend that you use multiple types of ads. So for Grindr, for example, we use both ad banner that shows up at the bottom of the screen. So this is actually the GIF that's displaying different images and text. And then we've also done the pop-up ad campaign, which is the larger image that you see that says looking for a few good men. So both of these ads should still link to a landing page, and this landing page would have information about your organization and then link to the survey instead of just going directly to the survey without giving any type of information. Because unlike with the Facebook ads, you don't have as much space to get across that trustworthiness, for example. Next, you should determine the scope of your ads. So do you want them to run locally? Do you want them to run in multiple specific sites, so for example, specific cities? Or do you want it to run nationally? And when you're determining the scope, you should also keep in mind that all of these different options have different price points. And then finally, we've seen that the most successful ad campaigns have included shirtless men in flirty language, as you can see in the ads that I've used for examples. And something else I wanted to note was apps like Grindr is that you may have some restrictions placed on some of the things that you can include in your surveys or in your ads due to some of the bad press that apps like Grindr have gotten following research publications on risk behaviors. Another site that we've advertised on has been Craigslist, and this is a little bit different from some of the other places we've advertised because you can do a breakdown in terms of people like volunteering their time as we typically think about for research studies, or you can do advertisements on the personal section. So I'm going into the Men Seeking Men, for example, section to try to get people interested in the study. So if these aren't particularly relevant categories to your study, you can post in other categories. The main idea is to just post in multiple categories to increase your visibility. There's also a map feature that allows you to enter specific location information for your organization. So, for example, with the volunteers posting, a zip code is required, but this is also helpful for you too, because getting back to one of the issues that Mallory mentioned earlier, if a participant or a potential participant is aware at the very beginning that your study is located in an area that might be difficult for them to travel to, they'll already have these considerations in mind and maybe think twice before they sign up for your study. Images are also allowed in the post, so this is helpful for catching people's eyes, and you can once again use images that focus on couples or attractive men or other things that work for your study depending on your target population. And then something to note is that URLs are not allowed in personal ads. So instead of linking to your screener that's online, you would just have to monitor your inbox or email responses. And then a very key thing for Craigslist is to make sure that you're posting at least twice a week. And this is, once again, to increase the likelihood that your post will be seen before falling to later pages of postings, because there's a high turnover rate on Craigslist with posts. And then this is just an example of one of our Craigslist ads. So you can see we have a catchy title. So we include that the Northwestern University for the trustworthiness. You have LGBT to give people a sense of the group that we're looking for. And then, of course, we have information about it being paid. And then the good thing about Craigslist is that you do get a little bit more room to go in more depth about your study and your program. And once again, that map is over to the side for a potential participant's reference. So these last two sections of the webinar, logistical fixes and communication, are going to be particularly important for retention purposes, but there are some places that you might also notice that is applicable for recruitment as well. So the first logistical fix that we're going to talk about is scheduling. So a big thing is to make sure that you are able to provide flexible appointment times for your participants. So makeup sessions are very important because as many of you may know, often participants aren't able to make their original appointment time. But when you're thinking about having makeup sessions, you also have to consider whether or not your staff are willing or able to work outside the standard 9-to-5 workday. Something that's also worth thinking about when you're trying to have flexible appointment times and doing scheduling is service integration and strategic scheduling of appointments. So for example, if you have a trans individual that you know has to come in for their hormones, or you have an HIV positive participant that you know has to have an appointment to get their medications anyway, you can also try to tack on your intervention or your program during that visit, so you're kind of killing two birds with one stone. And then the location and timing of interventions can be a barrier, but you can also think of it as a facilitator. So you want to schedule interviews and appointments in or near a targeted community when possible. And then you also want to think about offering weekend or after-hour clinics, even possibly conducting interventions off-site to accommodate your participants. So the impact program, for example, we have evening staff hours where where staff members are required to work at least one evening shift per week. So they work from 11 to 7 instead of 9 to 5 to be able to offer that flexibility to our study participants. And then, of course, there's also flexibility with work schedules when we're doing outreach, because once again, we want to be really flexible with our participants throughout the course of their participation in the study. And then next, we have incentives. So there are monetary incentives, of course, so there can be gift cards, but something that you can also think about are transportation or parking stipends, and this once again gets to some of the socioeconomic issues that Mallory mentioned earlier. So if you know your participants are struggling with paying for transportation, you may want to offer these. But the great thing is that beyond the monetary incentives, you can also offer non-monetary incentives, and this can be particularly great if you are worried about the monetary incentives getting so great that they might be coercive. So some non-monetary incentives that you might want to consider are access to additional services and resources. So for example, something we mentioned earlier was the possibility of participants who were HIV negative not having as much incentive to participate in HIV prevention programs, but you can tie in some other services like regular free HIV and STI testing and treatment, maybe some referrals to PrEP and PEP. Also, you might want to offer for your younger participants school credit if possible, and really hype up the aspect of them being a positive influence on their peers. And then there are other goods as well. So you can give out awards, for example, for periods of visits completed. So if you have a participant who's completed every single assessment, you might want to give them a certificate for that. And then there can also be raffles for awards where an entry is received for each clinic visit attended. So this is kind of getting at the same thing, but you would have a quarterly draw for your winners. So once again, the main important thing, though, was incentives. It's just to make sure that you're not being too coercive with them. And then we also have, as another tip for retention purposes, communication. So when you're contacting participants, you want to have steady appointment reminders. So it's good to have multiple methods of contact. So for example, with impact program studies, something that we do is try to get 3 different types of contact information. So a phone number, email address, a Facebook name, also contact information from friends and family if that information changes regularly for our participants. You also want to make sure that you find out what methods the participant prefers and use those, because you will notice that it actually makes a difference. So we found, for example, that younger participants are partial to using text messages rather than having phone conversations. And then you also want to make sure you capture your participants' general availability, so asking them if morning or evening times are better with contacting. This is particularly important if you have younger participants who might be in school during the day or participants who are working during the day. And then you also want to utilize a service like Google Voice in order to streamline your communications. So this is a great way for keeping track of all the communications that have happened between participants and multiple staff members, because Google Voice keeps a record of every single call and text message. But if you can find another service that does the same type of thing, you should feel free to use that. And then another important thing is to make sure that you have multiple points of contact. So you're not just contacting your participants the day of the appointment. You're maybe doing it the week prior or the day before as well. So it's typically good to send at least 2 appointment reminders, one the day before and one the day of. But like we said, you can do more. But you also have to be aware of possibly crossing the line. So you can be persistent, but we don't want you to be too aggressive and to turn off your participants. And then when you're also communicating with your participants, it's important that you are providing clear information to them throughout the course of your study or program. So you want to provide information about the program before, during, and after its duration. And you can do this through providing copies of your program protocol. So when you do provide the protocol, you want to make sure that it includes information so that participants understand what's expected of them and what to expect from the program, and to understand inclusion and exclusion criteria and whether or not they match them well. And to the point of inclusion and exclusion criteria, it's good to really go over that because, like Mallory said, sometimes you can have changes in it that can confuse participants later. So with my project in particular, for example, you have to be HIV negative to initially participate, but if you do seroconvert at some point during the study, you are still allowed to participate. So we really try to make sure that our participants know that, so they don't think that, you know, they can't participate, and for that reason we lose them we lose them in terms of retention. And then you also want to make sure to disseminate results to participants at the end of the study, because you'll often find that your participants are interested. So typically, like, doing that maybe in the form of a newsletter or letting them know about conferences or papers that are coming out that include information from the study or program that they were a part of. And then what I think is the biggest key for retention purposes, but also recruitment, is building rapport with your participants. So it should be an element of every interaction with potential or current participants. So you want to make sure that you have staff members who are comfortable with working with clients. And like Mallory mentioned before, it's also good to have people on your team that reflect the community that you are targeting. So when you are doing rapport building, it's good to build that familiarity and be friendly, but you also want to make sure to not be too casual. So you want to get to know your participants. And when you're getting to know them, you want to always be sure to treat them as people and not just as slots or numbers for your study or program. So something as simple as asking how your day is, or how school is going, or how the work project is, they're working on is going. Those are good ways to kind of build that rapport. You also want to make sure that you learn about the individual's motivations for participating and tailor your communications based on this. So if you know that your participant's very interested in the money aspect, typing that. If you know it's more about being a community leader, typing that aspect. And then making sure to continuously identify their expectations and then try to meet those. And then also during these conversations, try to figure out what kind of support system they have, and if there are gaps in that support, offer as much as you can and as much as professional to fill those.
Great. So beyond these tips and instructions for actually making contact with participants, you also need to be aware of the signs of attrition, so signs that a participant may be considering dropping out of your intervention or study so that you can combat those as soon as possible. So some of those signs are things like missed appointments or having to reschedule multiple times with a participant. Also just difficulty making contact if you call or email or text a lot and you're just not able to reach them. Major life changes can also be something that could signal a potential dropout from a study or an intervention. So this is a place where Crystal's point about building rapport and really getting to know your participants becomes really important, because you'll know these things that are happening in their lives. So, if there's a death in the family or a relationship ends or something goes wrong at work or school, that may be something that takes their attention away from some of the other stuff they're involved in, like participating in your intervention or study. Also, if maybe they're still coming to the sessions, but when they're there, their interaction is a little decreased or they're not as enthusiastic as they've been previously, that could be a sign that they're thinking about dropping out. And then, of course, outright complaints are something to take seriously when you hear them, because that could be a sign that they're thinking about leaving as well. So the last communication-related piece that we wanted to share before we give you one more case study and then open things up for questions has to do with managing participant rejection. So anybody who's ever been in charge of retention work has probably had a less than stellar experience before in trying to retain a participant. So staff that are working on retention may be yelled at or spoken to rudely or hung up on by participants if they're making contact via phone. And it can be really easy to take this personally and to feel like it's about you when it probably isn't. So learning how to manage that discomfort with participant rejection is important for your retention staff. So they need to know, what they should do if and when this happens. So first and foremost, they should debrief with a supervisor about the interaction and get some feedback about how to proceed. And more generally, this staff supervision and regular team meetings are really important, even when you're not dealing with a negative situation, because that can be a great space for brainstorming and thinking about innovative ways to engage and retain participants. So after debriefing with a supervisor, you should make sure that they also make note of any negative interactions in retention notes that you're keeping, whatever those look like, so that, one, it's documented, and then two, if you aren't operating on sort of a caseload style retention work where there's the same staff person contacting the same participants all the time, there may be multiple staff people that are interacting with a given participant, and so you certainly wouldn't want some other staff person to contact that participant not knowing that the last interaction wasn't so great. And then when you do make contact with them, keep the conversations really focused on them and their relationship with you and the project. Don't make it about, talking about that bad interaction you had before or reprimanding them or anything like that. Make it about, I'm just calling to check in and see how you're doing. So before we open things up for questions and discussion, we have one more local case study to share, which highlights the use of a number of the strategies and tools that we've discussed in the webinar so far. So I'm going to hand things over now to Christopher Raley from Howard Brown Health Center to talk a little bit about his project and recruitment and retention activities with that.
Hello, everyone. In the final two slides here that I have, I'd like to give you a very brief overview of my intervention that began at the beginning of this year. Medication adherence consultant is my title. Medication adherence consultation is the intervention. It's designed to provide collaborative, short-term intensive support that assists consenting participants in overcoming barriers to consistent and healthcare provided recommended ART treatment for HIV disease. So my program provides consultation, education, 6 months to a year of support to youth and adults who struggle with adherence to HIV medication. They have a detectable viral load of 200 copies or above. The time of participation in my program can vary, again, up to a year or more. The goal of it is to help the participant achieve viral suppression and or maintain viral suppression during the time frame. The services are offered to newly diagnosed persons with HIV, individuals who have never engaged in HIV care, those who have not had an HIV appointment in the last 12 months, or those who may also be at risk of falling out of care and need support reinitiating medications for their ongoing treatment. It is designed, but not limited to serve men who have sex with men and trans women within the city of Chicago. So let's see. Some of the recruitment strategies are kind of built into this program because it operates within a patient-centered team to integrate key components during appointments to gain buy-in among the patient population. My program engages, consults, and collaborates with all key staff within the Howard Brown Clinic to provide necessary direct service to clients. Those key staff are case managers, linkage to care staff, medical providers, behavioral health specialists, and other people that may be points of contact for the client or possible referrals to collaborate around comprehensive support and assistance to the client. So one other way that I identify potential clients is through the electronic medical record that we have at Howard Brown, and that is auditing charts for lab results to kind of identify folks that are coming in for the day or that week who have a viral load of 200 or above, as I mentioned earlier. And I will have a day and a time that this person is coming in, and I will know who their primary care team is, and I can reach out to that physician or nurse to alert them that I can potentially meet with that client that is coming into the clinic. I can meet with the client immediately upon any referral from any of the key staff that I mentioned earlier. And again, it can also be done during the office visits in the clinic. So another way that I can receive referrals is through a Mac. What I've created is called the Mac Desktop. It's in the EMR. So if I am not available, working with other clients or out of the office, then key staff can always flag my desktop to reach me and list just in a brief consult note about why they are referring the client, and then I can follow up in auditing that chart and reaching out to that client again within 24 to 48 hours for barrier assessment and intake completion. So that is kind of the way that my recruitment works in this study. Since April, I have had a total of 35 enrollments with many folks reaching viral suppression. I think I've had about 15 reach viral suppression since then and are maintaining that. And another big piece to referral and recruitment for my study is through a clinic that has been operating within Howard Brown for about a year. It is the Patient Application Clinic, which helps clients gain access to ADAP and other patient assistance programs to get access to their HIV medications. And when those folks come in for those appointments, that intern staff also assesses those individuals while they're in those appointments, conducting a very brief eligibility assessment with them, and the client answers a few questions and then lists or ranks some barriers that they feel that they have to medication adherence. And then if available, I can meet with that client immediately and then also follow up with them on their ADAP application that the intern just completed with them. So that is a chance, that's kind of my initial contact with folks and how that works to get folks recruited and enrolled. And within that, there is, on the consent form, there are multiple ways that the client dictates or informs me of how it is okay to contact them. They're given an opportunity to list an emergency contact. Is it okay to text? Is it okay to send emails? Is it okay to leave voicemails? Everything is very confidential and client-centered. So in saying that, in getting folks to stay in the program, again, as everyone has mentioned earlier, getting to know the client. Upon the assessment, reach out begins in this intervention, and it is conducted on a monthly basis or as needed by the client. And what that means is clients can be met with at all of their medical appointments during the intervention, and then anything else, any other things that pop up with the client in between those medical appointments. And in those sessions, counseling and education around HIV medication and adherence is discussed, but also other needs that the client may have. So if they're working with a case manager, or if they want a case manager, or if they need a referral to behavioral health, if they have questions about insurance enrollment, any adherence tools, condoms, pill boxes, those kinds of things are given at that time. And I help to facilitate all of the referrals for the client that they may state that they need. Home visits are not something that happens very often, but it is a way for me to also open up contact with clients that cannot maybe get to the clinic through, whatever barrier that they may be facing. So I can go to folks in the community and meet with them in their home and provide all of the previously listed services. So that's kind of my intervention in a very small nutshell. So I guess I will turn it back over to Mallory, and if there's any questions for my study or my intervention, I'll be happy to answer those.
Great. Thanks, Christopher. And before we jump to questions, just a really quick thank you slide to all the people from the Evaluation Center. A thank you from us to all the people that contributed. So we have a few folks from Impact, Antonia Clifford, Crystal, who's on the line today, and then Paul Salamanca, who helped with putting the PowerPoint together. A thank you again to Christopher for being here to talk about his intervention at Howard Brown. Raymond McPherson and Patrice Williams from John H. Stroger Jr. Hospital of Cook County, who helped out with content development. Joshua Oakes here at the AIDS Foundation of Chicago that helped with a lot of the logistical stuff related to actually hosting this webinar. Dwayne Quintana, who is here to answer questions and provide other insights in our discussion and QA session. And then Dwight Hunter and Patrick Stonehouse from CDPH.
Okay, so just as a reminder, we have this question box that you can type your questions in if you want to ask questions. We have a great group of people here who will be happy to answer anything you might want to ask. You can also feel free to email Mallory or me after this webinar. So feel free to type in any questions you might have. We'll start off with something that we already have. So Mallory, if you want to just pose one of the questions we've already received to the group, and we can get the discussion started.
Sure. So I know one of the things that has come up in the Evaluation Center's interactions with a lot of the sites throughout Chicago that are funded by the health department to do different interventions is the challenge, which we've mentioned earlier in the presentation, about recruiting and retaining HIV-negative clients and interventions. So I know we identified some of the things that can be helpful in this webinar, but I want to open it up to the group to talk a little bit about any experience you have working with HIV-negative clients in particular, and how best to keep them engaged.
With Keep It Up, as I mentioned before, we enroll participants who are initially HIV negative, and the majority do stay HIV negative throughout. So what we've done a lot of is actually linking our participants to other resources. Like I mentioned, PrEP and PEP have been particularly of interest to our participants. Even though we also do STI testing for gonorrhea and chlamydia, we've also gotten requests from people for us to help link them to testing and treatment for other STDs like syphilis. And it's been particularly important for us to help with linkages to care for our participants who are outside of the 3 main cities, so Atlanta, Chicago, and New York. We have participants that are in pretty rural areas or even suburban areas where they don't have as many resources. So they typically don't even know where to get started. So that's an example of some of the resources that we provided for our HIV-negative participants. And we've also heard back from the participants that they have seen the intervention as useful for them, and also like passing along information to other friends who aren't involved in research.
Great. Thanks, Crystal. I know one other thing that we've talked about internally at the Evaluation Center too that could be useful for motivating HIV-negative clients or any other clients that you maybe have trouble keeping them engaged or recruiting them into interventions is the use of motivational interviewing, or MI, techniques. So a lot of people on the line have probably heard about this before. It was originally developed in the 80s for use in the addiction field. And a lot of the core principles of MI are actually used in HIV test counseling. So anyone who's done that before is probably familiar with a lot of the basics and those basic techniques with MI. So it's a client-centered and technique that's focused on helping clients work through ambivalence they may have about enacting a certain behavior or maybe joining a particular study or intervention, and to increase their motivation to change. So it's different from more traditional techniques where there's a practitioner or provider that's sort of the expert or the authority offering advice or directives. So MI counselors are really just there to help guide a client into making their own decision by using techniques like reflective listening and things like that. So I think that's something to keep in mind. There are opportunities to be trained in this. I know that we have folks on the line that are from outside of the Chicagoland area, so I'm not as familiar with resources, specific ones, in all of the places where the webinar participants are coming from. But I do know that there is an organization called MINT, which is the Motivational Interviewing Network of Trainers. And so you can go onto that website and look for providers who have gone through a Train the Trainer session that are in your area, and figure out what it takes to actually get a training like that, how much money it would cost, sort of the logistics behind that. So I think that's something to keep in mind. That could be a really useful technique because when you go through training, they seem really simple, but can be really useful in identifying barriers and facilitators for engaging in a particular behavior or engaging in the work that you're doing. Any other questions that have come in, Gregory?
So just a question. So some people have lots of challenges trying to recruit people into these HIV studies, particularly for MSM who may not be out or willing to disclose their sexual orientation. So are there any suggestions on ways to find or engage these people into these programs?
This is Dwayne. I think one of the things that we've struggled with a lot, I basically come more from the community side of things, not necessarily the research. So one of the things that we've been learning, I think one of the things that to keep in mind is a lot of the time when we're trying so hard to reach people who haven't been reached already, that we kind of naturally take a space of being an authority, sometimes a mentor, sometimes somebody, a connection that somebody hasn't had yet. Many times we try to approach it in the sense of being transparent as far as why we're there, but also first trying to build some sort of relationship. So we spend a lot of time on social media like Jacked or Grindr, talking with individuals and really trying to, I guess, get to know them first or create some sort of like initial like, hi, how are you? What are you up to? Those sorts of things before we kind of get into the meat of why we're there. So our profiles or things might say who we're with and that we're obviously like health educators or part of research, but that we kind of really try to build some sort of like casual conversation and interest in them before we kind of get going with whether we're trying to get them into research or provide them some sort of service. So I think it's just really important to keep in mind that you, like, I don't know, I think building that rapport is really, I think, the strongest thing that you need to spend time on. And once you can kind of relate to that individual, check in about family stuff, job stuff, housing stuff, if those are things that are brought up in your conversation, and really kind of coming back to those, as Crystal had mentioned earlier in the slide set.
Great. Thanks, Joy. I think another piece, too, is something that we mentioned in the slide set. Well, a couple of things related to folks that maybe aren't out or don't identify as MSM or a member of the LGBT community, or whatever your demographic you're going for, is the piece about confidentiality and doing what you can to ensure that, and then also the flexibility piece in terms of meeting a participant in a different location if maybe they're not comfortable coming to an organization that is known in the community as an HIV serving one or an LGBT serving one. So I think thinking about those things, and again, as Dwayne commented on, this is all part of the building rapport piece and really getting to know who your clients are.
And we just got another question that's relevant to something we talked about before, but someone asked about specific recruitment strategies or scripts that have been helpful to link people to added service for people who test negative. So some key motivators for people to actually want to link to services, and if there's any experiences people have had with what varies by individual, if there's certain people who are more likely to engage in services or people who need more work.
Well, for Keep It Up, we had a general script that we gave to recruiters that obviously had information about the study, but we really did emphasize during our trainings with the test counselors that when they were pitching the study, they should make sure to integrate different motivations or motivators that they noticed during their conversation with their client. So, for example, if there was something about not knowing how to use condoms correctly that came up during the conversation, then that was integrated into like the pitch for Keep It Up, saying like, oh, you'll learn about that by participating. It's really hard to say like what the most important motivators are because it varies so much. But the most common ones that we've seen, like I mentioned before, have been just like involvement in the community, learning more about how to protect themselves against various infections, incentives, obviously, and then trying to think if there are any others besides those. I think just being involved in a study is really a motivator for some people, just like the actual experience of that. But beyond that, I mean, I'm sure that there are some that I'm missing, but it's really hard to like pick the top 5, I guess, or top 6.
Just to kind of add to that, this is Dwayne a little bit more. I think it's difficult because there aren't a lot of programs available for people who are at high risk for HIV, who aren't positive. Once somebody tests positive, there's so much we can do for them. But if they're just at high risk, there's very little support that we can help out with, say, housing or mental health or substance, those sorts of things. And so I think one of the things that, just to kind of iterate, like we work a lot with trans individuals, and we actually have a lot of services at our agency. So we can help with like connecting with hormone therapy or housing or legal services, or even providing safe spaces for people to get together with folks like themselves. So I think we're doing that very well with trans individuals, but I think that we're still struggling with trying to figure out how do you create those spaces. Really, I think more so for social interactions or opportunities to just be with people like themselves to kind of express and begin to plan that. So I think a lot of what we've been trying to do is build out one-on-one relationship with individuals, and then we can learn kind of what more needs to be developed in order to kind of meet that need. And again, because we are a community-based organization, but that's really what we're wanting to do, is really find out how we can create relevant programming and activities for the communities most vulnerable for HIV.
Okay, great. That was very insightful from both of you. So another question we have is, are there any networks or listservs that could help organizations connect and refer potential participants to each other?
Yeah, and I think that I'm not sure where the question's coming from, and if it's someone here in Chicago or elsewhere. I think that this is a conversation that's come up a lot. I know the Evaluation Center has had with different sites that are funded by the health department is the need for something like that. You know, I think that the Center on Health has a hotline that can be used for HIV and STI resources here in the city, but in terms of there being sort of a more robust kind of forum for whether it's, you know, a website or what have you, where people could really go on and, you know, have this one place that you can go and you can see the other agencies in the city and who they're serving and what interventions they're doing and what studies they're working on. That, to my knowledge, and if anyone else in the room has different knowledge you can share, doesn't exist, but I think it's something that would be really beneficial. I think that as of now, probably the biggest resources that people have beyond that hotline that I mentioned was any like hard copy resource, like binders or folders that different agencies have, which are obviously a challenge because those are a little more static, and if you're having something printed out and have to update that again and again, it's not something that can be kind of like a live document online. So I think that it's a great question, but to my knowledge, I don't know that there's anything that exists that is as robust as would be needed.
And there's a few groups in Chicago specifically that they might be able to access. So the PrEP working group is one place where people can talk to others who either are working with prescribing PrEP or on projects that involve PrEP that people could be referred to. And another major one is CAHISO, the Chicago Area HIV Integrated Services Council, which has a lot of members from across the different community-based organizations and other service providers in the city that might be a good resource. However, as Mallory said, there aren't very many written documents or anything. It's more these groups that you would have to communicate with. Okay, another question we had is any advice about reaching HIV-positive individuals who have mental illness in order to get them to take part in an intervention or program?
This is Christopher with Howard Brown. I can speak a little bit to that. As a licensed professional, a licensed clinical social worker, and a certified alcohol and drug counselor, and then working within a medical clinic, we see a lot of substance use. We see a lot of varying degrees of mental illness, whatever that may be, from general anxiety all the way to schizophrenia or what have you. So my program and intervention is definitely open to any of those individuals. And a lot of times what I have found is most successful is using some of the techniques that we've talked about before, motivational interviewing, very client-centered approaches, collaborating with anyone else that the client may be working with, and also kind of just helping them to sort out everything that's happening to them wherever they are in the cascade of care for HIV, if it be understanding what lab results mean, just something that simple, to doing very basic appropriate language around educating HIV, not being too clinical, providing support, reaching out to them, going and visiting folks in their homes. All of those things I have found, because my first position at Howard Brown was in retention and care, and the reason that it was successful is because those things were a part of what I was doing. So always remembering just, the client comes in with varying degrees of concerns, and one person who has anxiety or depression is not the next person who has anxiety or depression, if that is a barrier that they list around adherence or staying in my intervention. So I can't speak to other interventions, but for me, it's really just continuing to not give up. If a client, if a client is not wanting to continue to engage, just kind of affirming that and documenting that, and then offering to re-engage them whenever they are ready.
Great. Thanks, Christopher. So I think that we probably need to wrap things up now as we're approaching time. If there were any other questions that have been submitted, we can be sure to answer those via email if you want to share that information. Also, again, on the screen there is the contact information for myself and also for Gregory. You can feel free to email us with any questions or comments after the webinar is closed. And then we just wanted to acknowledge the Evaluation Center team here on this slide. So Gregory as the principal investigator, our co-investigators, George Green, C. Hendricks Brown, and Amy Johnson. And then staff, myself, Juan Villamar, Emily Betton, and Greg Swan. And then from our funding agency, the Chicago Department of Public Health, Patrick Stonehouse and Dwight Hunter. And then we have our references listed here. We'll be sending out the actual slide set in PDF format to all of the participants today, so you can have access to that. We'll also have a recording of the webinar, so with this audio and the slides themselves that we can email out, and that we're also going to archive, I know for certain, on our website at the Impact Program, and then potentially in other places too, but we'll send an email out to everyone on the line today to have that information.
Thank you, Mallory, and thank you, everyone, for your questions and for being involved in this webinar today.